Fluid on the lungs, known medically as pulmonary edema, and kidney failure are serious health conditions that can have severe consequences if not treated promptly. Pulmonary edema is characterized by an abnormal buildup of fluid in the lungs, which can cause symptoms like difficulty breathing, a feeling of suffocating, and a rapid heart rate. In contrast, kidney failure, also called renal failure, leads to symptoms such as edema elsewhere in the body, changes in urine output, and fatigue due to the kidney's inability to filter waste effectively. Treatment options for each condition vary, with pulmonary edema often requiring oxygen and medications to remove excess fluid, while kidney failure might necessitate dialysis or even a kidney transplant. Risk factors for developing these conditions include heart disease, high blood pressure, and diabetes, among others. Here's a look into the more detailed aspects of fluid on the lungs and kidney failure. Etiology: cardiogenic versus nephrogenic. Fluid accumulation in the lungs, known as pulmonary edema, and kidney failure can both be manifestations of underlying systemic conditions, with etiologies spanning cardiogenic and nephrogenic origins. Cardiogenic sources pertain to heart dysfunction, where the heart's weakened pumping ability leads to fluid backlog in the lungs. This often results from conditions such as congestive heart failure or acute myocardial infarction. On the other hand, nephrogenic etiologies relate to the kidney's capacity to manage fluid and waste. When kidneys fail, fluid can build up systemically, including in the lungs, often due to chronic kidney disease or acute kidney injury. Differentiating between these sources is crucial, as it directs the approach to treatment, managing cardiac function or improving renal filtration to effectively address the primary cause of the symptoms. Symptom onset: acute versus chronic. When considering fluid on the lungs and kidney failure, acute versus chronic onset symptoms play a crucial diagnostic role. Acute onset might suggest a sudden event, such as heart failure, severe infection, or acute renal failure, triggering pulmonary edema, with patients experiencing rapid breathing difficulties and possibly reduced urine output. Acute kidney injury can similarly result in fluid overload due to decreased urine production. In contrast, chronic symptoms often align with long-term conditions like chronic kidney disease or interstitial lung disease. Here, fluid accumulation and renal decline happen over months to years, leading to a gradual increase in symptoms such as fatigue, persistent cough, and a progressive decrease in kidney function. Identifying the acuteness of symptom development helps healthcare professionals pinpoint the cause and tailor appropriate intervention strategies. Treatment focus: diuresis versus renal replacement. When managing a patient with both fluid on the lungs, pulmonary edema, and kidney failure, healthcare providers face a challenging differential diagnosis that demands a finely tuned treatment strategy. Pulmonary edema necessitates the removal of excess fluid to alleviate breathing difficulties, which is typically achieved through diuretics. However, if this condition coexists with kidney failure, the use of diuretics becomes complex. Kidney failure often limits the ability of diuretics to effectively remove fluids and could even exacerbate renal damage. In cases where diuretics are insufficient or risky, renal replacement therapies like hemodialysis or continuous renal replacement therapy may be indicated to manage fluid overload without further compromising kidney function. The treatment must balance the immediate need for fluid removal to improve respiratory function with the long-term need to preserve or improve renal health. Underlying cause: pulmonary versus systemic. Fluid accumulation in the lungs, known as pulmonary edema, and kidney failure can both be life-threatening conditions, marking a possible intersection between pulmonary and systemic diseases. When the lungs are affected, it could stem from direct pulmonary causes, such as pneumonia or congestive heart failure, where the heart fails to pump blood effectively, leading to fluid backup. On the other hand, kidney failure might precipitate systemic volume overload, as the kidney's capacity to excrete fluid diminishes, potentially causing secondary pulmonary complications. Differentiating between primary pulmonary pathology and a systemic process with pulmonary manifestations is critical for providing targeted treatment, as management strategies differ significantly between heart, lung, or kidney-oriented therapies. This differentiation often involves a combination of clinical assessment, imaging, and laboratory tests, including measurements of cardiac function and kidney health markers. Manifestation: respiratory distress versus uremia. Fluid on the lungs, medically termed as pulmonary edema, presents a critical situation where respiratory distress is a key feature. Patients experience shortness of breath, particularly when lying down, and often a cough that may produce frothy sputum. This respiratory distress is typically a direct consequence of excess fluid accumulating in the lungs' alveoli, leading to impaired gas exchange. On the flip side, kidney failure can lead to uremia, where the accumulation of waste products in the blood produces a distinctive set of symptoms due to kidney dysfunction. Instead of the acute respiratory symptoms seen with pulmonary edema, uremia can induce a more insidious onset of symptoms such as fatigue, confusion, nausea, and a metallic taste in the mouth. The kidney's inability to filter the blood efficiently leads to a buildup of toxins that can affect multiple body systems. Understanding the nuances between respiratory distress symptoms from pulmonary causes versus systemic manifestations of renal failure is essential for accurate diagnosis and timely treatment, which can drastically differ for these two conditions.